Right. Thank you, Dr. Louis, for having me, and thank you, everyone, for staying here this late today. So, all right. So, why we're giving this talk in Chiari session? Well, a lot of time patients get referred to Dr. Louis for Chiari, and then he finds out they actually have CSF hypotension. And the problem is that when you are leaking a lot of CSF at the spinal level, your brain can sag, and you can have an MRI that looks like a Chiari. But if you pay attention to other details like meningeal enhancement or whatnot, then you know it's a CSF hypotension situation. The symptoms also overlap a lot. So spontaneous intracranial hypotension or CSF leak affects approximately 5 in 100,000 individuals. So it's not too common. There's more preponderance for females, and usually they're around the middle age or a bit younger sometimes. The symptoms, everybody talks about the CSF leak symptoms, usually are headaches, and headaches that are positional in nature. So when you're lying flat, they goes away. When you stand up, they get worse because you're losing more fluid. But as time goes and the brain adapts, the headaches become chronic. So you lose this positional component, and then it makes the diagnosis harder. Also, as time goes, you start to develop symptoms of foggy brain, difficulty concentrating, fatigue, lethargy, which are symptoms common with every disorder. And then you start having dizziness, tinnitus, and photophobia, and now people start asking, is it IIH or low intracranial hypotension? So as you can tell, as time goes by, it becomes a challenging diagnosis. And then the brain starts to sag, and then you develop dysphagia and dysarthria, and even dementia at the end. So just to clarify a point, we're talking about CSF leak that are not related to someone who had surgery and they leaked. These are spontaneous leak. They just happen. We don't know exactly why. We have some theories. And because they happen under the skull base, you can sag, and you can have all those symptoms and an MRI that looks like a Chiari. This is an advanced case where you see all those dark things around the brain and in between the fovea of the cerebellum. These are hemosiderosis, and it can happen if the sagging is very chronic. And then this is the hemosiderosis is irreversible even if you fix the leak. So there are 4 types of leak. Also, there's a lot of debate on how you classify them, but this is mostly acceptable. You have the CSF venous fistula. So the spinal fluid is not leaking in your spinal column. It's leaking into a vein, and it's being drained by a vein, which it should not be. So it's not going through the typical pathway. So it goes from the spinal column to the vein. This is one type. It's called the CSF venous fistula. And then you have a second type. It's a nerve root sleeve leak. There's leakage around the nerve root, but this is usually, it's leaking in the spine. You have a dural tear spontaneously. The dura, if it's thin, if you have Ehlers-Danlos, Marfan, or other pathologies, or even it just happen in mostly in women of middle age or older. You can get dural tear, and then you would have a CSF leak. It's leaking from the spine through the dura to the epidural fluid. You have idiopathic, meaning we can't find the leak. And this is not uncommon. All of these, you cannot diagnose them based on the symptoms. So they all have the same symptoms. You have to do some investigation. It takes a lot of collaboration with our radiologist to figure it out. So there is a diagnostic challenge and there's a therapeutic challenge. The first line usually is epidural blood patch, and its effect is in about 13 to 90%. This depends a bit on the pathology. For a CSF venous fistula, we skip the blood patch. We just go for transvenous embolization. There are targeted blood patch. So a non-targeted blood patch is you just inject high volume in the lumbar spine. A targeted blood patch, you suspect where the leak is, and you try to go in and inject the blood patch at that level. There is surgical repair, especially if you can really see the leak. If it's one dural tear or a leak at the level of one nerve root, then you can open the bone, microsurgically suture it. And then there is a transvenous embolization for CSF, spinal venous fistula leak. And what you do there is you just go into the veins of the patient. You enter the femoral vein, and you drive all the way to the spine to the spinal veins at the level of that leak. And you give something called onyx, which is like a glue, and you just shut it down. It's very effective. So the type of leak, like I said, you have 4 types: dural tear, dural dehiscence or nerve root leak, CSF venous fistula, and occult leak. But the big point here is If you look at the proportions, they're different because depending on who's doing the diagnosis, but there's one important thing is something called a SLAC, spinal longitudinal epidural column. If you have spinal fluid in the epidural space, this cannot be a venous fistula because the spinal fluid is going in the spinal column, not in the vein. And this is important because this would help us to treat, because if it's a venous fistula, everybody does transvenous embolization. It's a standard of care. But if it's not a transvenous fistula, then it becomes a challenge. They usually fail blood patch. So what do? We developed a technique. We did a lot of literature review and we added some stuff and we developed a technique that we called CAST, which is supposed to be reproducible by pain clinic, neurosurgeon, neuro-IR, and radiologist IR. So they can, it's feasible. One thing that can help with the diagnosis that we don't have here is you can measure the optic nerve sheath, and if it's, the diameter can be, there's some sensitivity and specificity because it can reflect the intracranial pressure. We don't use this here, but a lot of high volume centers are using it. It helps with IIH, it helps with SIH. So a bit of pathophysiology. So the pressure in the spinal vein is about 3 to 8 millimeters, and the pressure in the subarachnoid space is 7 to 15. The pressure in the epidural space is almost negative. So you can leak into the vein or into the epidural space because of this gradient of pressure. And you need this gradient because this is how the blood would flow. Otherwise, your spinal cord cannot drain. The veins of the spinal cord cannot drain. So how does the treatment work? Well, for CSF venous fistula, you shut it down with onyx. For the other, the blood patch, we're not exactly sure how it works. There's an immediate relief because you're increasing the pressure, so you're stopping the drainage, and the patient feels better. In the long run, you'd hope that the blood would create some fibrosis. So that's how we think it works. So what we developed right now is this technique that I'm going to go over a bit briefly. So the goal is to try to navigate in the epidural space by a safe access. So you, just like you do a epidural for pregnant patient, you use the same needle, you stick it in, and then you get access. And then you can navigate to the area that you want to patch, cervical, thoracic, lumbar, or if it's occult, you can't see it, you just patch the entire spine. So we gain access in the lumbar space. We use the microcatheter and the micro wires that we use in the neuro-IR and the endovascular suite, and then we can navigate up to the cervical spine and we can inject some contrast. So picture E shows you the microcatheter is at the tip of the skull base. And this is the contrast injection. Can we run the video? Or? So this is a 2-minute video of how we do the procedure. So we enter at L5S1, we inject some dye to make sure we're epidural, not intradural. Then you enter the O35 wire, it does this loop, which is characteristic. Then you put in your sheath, so you secure your access. Then you use a 4 French catheter with the wire to navigate almost up to the thoracic spine, but not more than this. Then we switch to microcatheter. If there is stenosis, very uncommon in the patient, then you can start with a microcatheter and a micro wire a bit earlier. And then this is the microcatheter and the micro wire getting up to the cervical spine. For thoracic and lumbar, I do it awake. For cervical, I do it asleep with monitoring. So you get up there, and then you do a run. You make sure you're still in the epidural space. You're not in. You didn't accidentally enter the veins because you don't want to treat. It's not a venous fistula. And this is the treatment: is you inject some solution that I want to talk about. And then you see under fluoro, you see where your solution is going. Okay, maybe next slide. So this is the solution after a 30 seconds of injection. So what we do is we take the Vistacil or Tacil, which has a thrombin and fibrin. We split them into 2 solutions, and we put some contrast in each solution so that you can see where they're going. The moment they mix, they become a hard plug. In those cases, we don't want them to be a hard plug in the beginning because we want them to diffuse all around the spine, and then we want them to harden to create a pressure and then to create some fibrosis. This is a video, just it shows you it's a 30-second or 50-second video, something. Okay, maybe the next, go back. One more. Okay, that's fine. You can go. Basically, you inject with the microcatheter this number 1 solution, then the second solution, and then you flush the catheter, and then in between you can inject the blood if you want to increase the fibrosis. We moved away from just using blood because blood doesn't diffuse. If the leak is ventral, you're not going to get blood to go ventrally, and you're going to cause cord compression. So that's why we are using this. We still use blood in between the levels just to promote fibrosis. These are not made to promote fibrosis. In fact, if you look at Duracell and Adiris, they try to make them to cause less and less fibrosis. So we want the fibrosis. Next slide. This is the one. I'm going to give a couple of case examples of patients. So the A, B, and C are pre-op. On the A plane, does this pointer work? Okay, that's good. You can see those subdural hygromas. They happen because as the brain sags, either veins get torn or there's more fluid accumulation. So this patient has a drastic case. Look at those subdural hygromas. Look at the posterior fossa, how crowded it is. We didn't do any surgery. We just did the treatment because she wasn't in. This is a chronic case, right? Acute cases, mass effect, you want to decompress them, but this is a chronic case. And then this is the follow-up. Everything is gone. Sorry, I guess I can do it from here. This is another type of patient. You see the pachymeningeal enhancement, meaning that there's a CSF leak. And then this is the MRI. There's some fluid anteriorly at the cervical spine. And you see it, when you do the CT myelogram, you see it extravasating. This case is probably at C1, C2. You can consider, and it was also posterior, so you can consider open surgery with microsurgical repair. But we talked to the patient and we did this technique. So this is the post-op MRI, it's gone, and this is the Vistacil all the way here, or the solution. And you can see this is an immediate CT scan showing the nice patch of Vistacil around the cord, and you can see it on the sagittal. So we passed the entire cervical segment, and the pachymeningeal enhancement is gone. This was related to a blunt trauma, actually. You start having leak after a blunt trauma. Probably has some dural dehiscence at baseline. But if the leak was ventral, you would have to do like a corpectomy or a transdural approach, which is very challenging. And this is elegant. Of course, if they fail, you'd have to consider something more aggressive. This is a second patient. Again, pachymeningeal enhancement, fluid at the epidural space, so it cannot be a transvenous fistula because there's fluid in the spinal column. Same thing with the myelogram here. And again, after the intervention, the pachymeningeal enhancement is gone, and as you follow it, this is the Vistacil in the spine. A third case, again, cervical epidural fluid, and here it's anterior, so we injected the solution a bit higher volume so it could go ventral to the spine, as you can see here. And this is the same patient showing you in a sine flexion and extension. The leak happens in the flexion, but not in the extension. It is some disorder of pulsation, I bet, and similar to Chiari, there might be some pulsation problem. And some of them have cervicothoracic stenosis, even though they don't have cervical spondylosis. And this is post-op. The fluid in the flexion is gone, so the leak is gone. This is our first 10 patient that we submitted for a paper. It's under revision along with the video. It's accepted that they wanted some minor revision. They wanted a bit more images and a bit more details of the technique. We had, when there is a spinal epidural column, the success rate was high. When it's occult with a spinal epidural column, the success is also high. When it's occult and there is no spinal epidural column, we only had one patient, luckily, but we had to do it 3 times. And it's been 6 months now that he didn't have any problem. We've also used it for baclofen pump. One of them had baclofen pump followed by revision with repair of the CSF leak and continues to leak, so then we did it. So we have 3, and then the next time this happened, they immediately sent it to us. They didn't have to do surgical repair. And we have one which has, we assume it's multiple after multiple LPs, but sometimes you can tell because they have symptoms for a long time, and someone think they have IH, they did an LP, and then they think they had some meningitis, they repeat the LP. So I don't know the etiology, but Couldn't find a leak, but there was some column in the lumbar spine, so we assumed it's post-LP. And the results were very good. We had one femoral nerve palsy from prone positioning that improved but did not completely resolve in 6 months. So our protocol now is if you have the clinical symptoms, we get an MRI to make sure it's a CSF leak with some objective signs. Then we get an MRI of the cervical, thoracic, and lumbar spine to look for the etiology and to look for epidural column. If there is, sometimes we do a myelogram, but it's not going to change what we do. We're going to do the cast. If there is no epidural column, then you have to make sure it's not a venous fistula. And you can either do a nuclear scan. If you see the contrast in the kidney, then you know it's a fistula. Or the gold standard is a digital subtraction myelography, but this requires a good neuroradiologist. And if you diagnose a fistula, you do a transvenous embolization. If there's no fistula, we call it an occult CSF leak without epidural column, and then you do a cast of the entire spine from the cervical down to the lumbar spine. This is a picture from Stanford, 7 Tesla, showing like the pulsation in the brain. I found it very drastic. All right, thank you. I'll leave some room for questions.